Morning, everybody. Glad everybody could make it this morning into class. I know today is President's Day, so some of you guys couldn't make it, so I wanted to do this reporting for you. But basically today what we're going to talk about is soft tissue injury repair and management. So it's important to kind of think about this as we continue on the next couple weeks. This is kind of the groundwork for what we're going to be discussing in terms of the spine, in terms of upper extremity and lower extremity management of various injuries. So if you have questions about this, if you have concerns after watching this video, please email me, or on Wednesday when we're in class. Just going to make sure that we reserve some time, or I'll make sure that I reserve some time for us to discuss some objects or some items and discuss them. So lots of different words and phrases that you need to be aware of when we start out with this particular chapter. So we're going to talk specifically about musculoskeletal disorders today. By the time that we're done, what I want you guys to feel comfortably able to do is talk about strains, sprains, dislocations, subluxations, what's the difference between those, the types of muscle tendon ruptures or tears that you might see, the difference between a tendinopathy and a tendinitis or tendinosis, what is synovitis, hemoarthrosis, the difference between a ganglion and a bursitis or bursa, what's the difference between a contusion, and some obvious overuse syndromes or cumulative trauma disorders or repetitive strain injuries. So some basic definitions before we begin. What's the difference between a strain or a sprain? So you're going to see a lot of physicians that are going to write this incorrectly on a script, and so it's important that you understand the difference between the two, because again, we are the musculoskeletal experts, and so we want to make sure that we're informing our patients and the people that we interact with what these terms mean. So a strain is basically an overstretching, overuse, or overexertion of soft tissue that occurs from slight trauma or unaccosted repetitive trauma. A sprain refers to a non-contractile tissue or a static stabilizer around a joint. So we strain muscles, we sprain tendons and ligaments. So again, strain dynamic stabilizers, the muscles that surround a joint, we sprain the passive or static structures that are around a joint that allow some stability. The difference between a dislocation and a subluxation is a dislocation is the complete separation of a joint. And so what that means is we have the glenohumeral joint, for example, and we're looking at the joint in its congruency. A dislocation is when that joint pops fully out. It's unseated. And so most of the time, you can take that joint, you can go to the hospital and they'll relocate the joint. The difference between dislocation and a subluxation is an incomplete or partial separation of the joint that usually self-reduces. You don't have to go to a hospital to get this redone. And there are implications for both these things in terms of what we as clinicians are going to do. So like a dislocation, for example, is going to generally lead to more soft tissue damage. There's going to be more inflammation, there's going to be more pain. Also with a dislocation, depending on where the area is located, you can have injuries to the nervous system, which we're going to talk about kind of a little bit later on in this lecture. And the other difference is with a subluxation, there's going to be some trauma to the surrounding tissue, but it's not going to be as severe as a dislocation is. So the next thing we want to talk about is tendon and muscle ruptures. So there's two different kinds of tendon injuries. There's a chronic injury and there's an acute injury. And so a chronic injury is generally what we refer to as a tendinosis, whereas an acute injury is generally referred to as a tendinitis. And so when we talk about those issues, a tendinopathy or tendinosis is a chronic tendon injury. A tenosynovitis is the inflammation of the synovial covering of the sheath or of the tendon. A tendovaginitis is thickening or inflammation of the tendon sheath. And then a tendinosis is generation of the tendon due to repetitive microtrauma. And so a good way to think about this is like, when somebody has an Achilles tendinitis, right? Achilles tendinitis is basically inflammation of the tendon that inserts on the calcaneus. Whereas if you think about de Quervain syndrome, that's a chronic tenosynovitis of the tendons that are in the first carpal or first tunnel of the wrist. A synovitis is basically inflammation of the synovial membrane. Remember, most of the joints in our body are synovial joints. And so what ends up happening is that joint itself gets irritated. Most of the time, what you'll see for a synovitis is think of the pathology of adhesive capsulitis. That's kind of the joint, the shoulder where the capsule around it gets inflamed, irritated. And then the other one, or the last kind of definition that you kind of need to understand is what a heme or hemaarthrosis is. So heme means blood, arthrosis of the joint. So bleeding into a joint is what a hemaarthrosis is. Other different definitions that are important are what's a ganglion, bursitis, contusion. A ganglion is basically ballooning of a wall of a joint capsule or tendon sheath caused by disease or trauma. So you might see people walking around with what are called Bible bumps or ganglion cysts, which are on the dorsum of the wrist. And so that's an example of what a ganglion is. Bursitis, the most common bursitis injury that we treat is like greater trochanteric bursitis on the side of the hip. Contusions, that's resulting from a direct blow, resulting in disruption of the capillary beds. That's why you get bruising. It's because there's breakage of blood vessels that cause the bruising to occur. So a contusion is basically a bruise. We'll refer to it as it having ecchymosis. It'll have a change in color generally. It'll go from kind of that ruddy purple color all the way to yellow to green, depending on what stage of healing it's in. And then we have overuse syndromes. And overuse syndromes are basically just accumulative trauma resulting in inflammation and pain of the joint. The next thing we want to talk about is how we classify these in terms of clinical conditions that are resulting from that trauma or pathology. So think of this as being stuff that we've already discussed. So this is like the ICF model, or when we talked specifically about contractures, or when we talked about adhesions. So dysfunction is basically the loss of normal function of a tissue area or tissue region. Joint dysfunction specifically results in the decrease in the joint mobility and the change in the osteo and arthrokinematics of that joint. So if you think about dysfunction are things that we generally measure, like manual muscle strength, range of motion of a joint, where joint dysfunctions are things that we generally measure, like passive active range of motion, joint play. So when we're doing our assessment for our joint mobilizations, this kind of falls into that. To rehash the difference between a contracture and just hypomobility, a contracture is adaptive shortening of everything: skin, fascia, contractile, non-contractile tissues that's going to impede or limit normal joint mobility or flexibility. Where an adhesion is basically the adherence of those collagen fibers that are around the joint that are going to aid in immobilizing the joint. That's generally caused due to some kind of trauma or complication from surgery. So adhesions are basically like scar tissue that gets laid down after an injury or after surgery, and that's going to impede motion. Now we can address those issues, adhesions, by using thermal modalities or ultrasound or other things that we've discussed in the class, soft tissue work, cross-friction massage, to try to break up or loosen those adhesions. And then we can use our manual therapy skills like stretching, range of motion, muscle energy techniques to kind of help lengthen that tissue some more. So this brings us into reflex muscle guarding and intrinsic muscle spasms. And so reflex muscle guarding is basically a prolonged contraction of a muscle in response to a painful stimulus, where intrinsic muscle spasm is a prolonged contraction of a muscle in response to a local circulatory and or metabolic change that occurs when a muscle is in a continuous state of contraction. And so basically when you have pain, your body's going to limit mobility. Pain is a symptom. It's not necessarily a bad thing. It just means that we're going to limit mobility in that area because it hurts. And so think about like if you sprained your ankle, or think about if you've had an injury in your life, how you didn't want to move the area because it hurts. Well, pain is going to limit that mobility. But that's a symptom, right? Whereas when you have an intrinsic muscle spasm, there are things on the microscopic level that are happening within the tissue itself that is limiting mobility. And again, this would be like changes in circulation, so you have decreased circulation in that area, decreased neural input in that area, changes that are going on that are toxic to that cell, it's going to limit that cell's ability to function and carry out what it needs to. That's like an intrinsic issue. So when we're talking about patients in general that are suffering from pain, and as a result of that they have a muscle spasm, that's what this chart is referring to. And so when you get a reflexive muscle contraction because somebody has pain, inflammation, infection, emotional tension, cold, or if they've been immobilized, that's going to restrict motion. Restriction of motion causes changes intrinsically in the muscle, whether it's going to be ischemia, decreased circulation, buildup of waste products, what have you. That is going to cause pain. That pain is going to therefore limit more motion. And it's a cyclical nature that we as therapists have to intercede and break up. And so we utilize that, or we use manual therapy, we use modalities, we use other things that kind of address pain to help break up that part of the cycle. We might do soft tissue mobilization or edema massage or passive range of motion to help with circulatory status. We might do stretching exercises, muscle energy techniques, joint mobilizations to work on restricted motion. And in turn, we're kind of taking out or handling different parts of this cyclical muscle spasm cycle and distorting it so that the patient can recover and function more appropriately. All right, so other things that we need to address and discuss is what's the difference between muscle weakness and then something called myofascial compartment syndrome. And so muscle weakness is basically a decrease in strength of a muscle contraction. We measure that with manual muscle testing. We can do that, we can look at that through observation when we want somebody to walk or ambulate, and we're looking at their gait cycle. Myofascial compartment syndrome is basically an increase in the interstitial pressure in a closed, non-expanding myofascial compartment that comprises the function of blood vessels, muscles, and nerves. And so this is kind of a big deal when we're talking about patients, specifically patients that have either broken a bone or patients who have exertional symptoms. So what I mean by that is, say you're working with a patient and they broke a bone and recently have been casted or have been immobilized. And they're talking to you about pain that is not proportional to their injury or proportional to what you think their symptoms to be. So like if you had a patient who broke a bone, they were casted in the hospital, the nurse came and had given them pain medications. It's been 30 minutes to an hour since they took that pain medication. But now when you go in to get them up to walk them or do gait training or transfers or what have you, they're still complaining of 10 out of 10 pain. They're still complaining of different things. What you have to be careful of in that scenario is a compartment syndrome. And so that's a red flag, that's an emergency, that's something that needs to be brought to the attention of the doctor immediately. Or if you're working with a patient and the PT might have missed this, where the patient is an athlete and maybe they get symptoms in their legs specifically only when they exercise. I run on the treadmill 30 minutes a day, and every time I get off the treadmill, or I'm on the treadmill, my legs feel like they're on fire, they feel heavy, I feel clumsy, it's hard for me to lift my feet. They might complain of different symptoms, and they say it feels better when I get off, but as soon as I get back on, the next day, it's this kind of exertional, activity-driven kind of pain. That's another example of what compartment syndrome is. And basically, that's a red flag, too, for us as clinicians, because that means that there is that natural inflammation process that happens when we exercise, but the body can't deal with it. It's creating pressure in a compartment. So generally speaking, in the lower extremities, we have that anterior, posterior, and lateral compartment for our leg. And then we have a deep posterior compartment. What will end up happening is people will get swelling in those compartments. It'll push on the muscles, it'll push on the nerves, and that's a medical emergency. They need to have a surgery called a fasciotomy in order to kind of open up those compartments and relieve the pressure that's building up when they exercise. All right, so transitioning here, we want to break down tissue injuries into three main portions. And so what we have here is a grade 1, a grade 2, and a grade 3 injury. A grade 1 injury is very mild. It's what we call a first-degree injury, and so basically that's mild pain and swelling. There's local tenderness. There's minimal fiber disruption. A grade 2 is a moderate or second-degree injury. Those are moderate pain, it is those individuals who have moderate pain and swelling that require activity stoppage. The examination increases pain because there are fibers that are torn and they're going to cause joint instability. Excuse me, and a grade 3 is very severe. It's a complete tear or an avulsion. Joint stress may not produce pain proportional to the degree of laxity. So what I mean by that is, like, if you're working with somebody or you know, say God forbid you have a patient in the clinic that fell, and the patient fell and they ended up falling on their knee. There's lots of different injuries that can result from falling on a flexed knee, but you know, it might be a mild injury, just a little bit of bruising, discomfort, not a big deal. It might be a moderate grade injury in which, because of the injury, they might have a little laxity or pain in the joints, swelling, things like that. Where a grade 3 would be a lot of swelling, a lot of discomfort, and the joint is really lax, but because things are completely torn, they don't have a lot of pain. You know, find somebody who's had an ACL injury, like talk to Emily and ask her how her ACL felt after she tore it. Was there a lot of pain? Maybe, maybe not. Don't know, gotta ask Emily, right? So, here's a visual representation for you guys, because I know a lot of you are visual learners, where it talks about grade 1, grade 2, and grade 3 injuries. Note the progression, note how in grade 1 there's this irritability of the tissue. Grade 2, there's irritability with some mild injury. And then grade 3, really significant tears and laxity that's going on here. All right, so let's pause here for a second, and we'll take a break. And then when we come back, we'll talk more about irritability of tissues.